Nutrition. You're at the grocery store, standing in the produce section, and someone put a bunch of kale right in your path. You grab a bag, not because you want it, because somewhere in the back of your skull, there's a nagging feeling that you probably should eat more of this. You put it in the cart. You might eat it. You might not. That vague guilt is actually pointing at something real. The cells lining the back of your eye are among the most metabolically demanding tissue in the entire human body. They're firing constantly, processing light, renewing themselves daily, doing all of this while soaking in near arterial levels of oxygen, which also means near arterial levels of oxidative damage. To handle that, they need a very specific set of nutrients, and most people aren't getting enough of them. What's actually happening is your retina is running on antioxidants the way a car runs on fuel. The photoreceptors, the cells that actually detect light, are packed with polyunsaturated fat that go rancid under oxidative stress, the way butter goes bad in sunlight. The antioxidants neutralize that damage before it accumulates. When they're in short supply, the damage builds up. Slowly, silently. Over decades, what makes this different from general nutrition advice is specificity. You don't just need antioxidants. You need particular ones, lutein, zeaxanthin, vitamins C and E, zinc, that physically concentrate in the retina and do the work locally. A multivitamin won't cut it. A diet built around colorful vegetables will. Spinach, kale, eggs, bell peppers, blueberries, citrus. These aren't just broadly healthy. They're delivering the exact compounds that end up in the macula, the tiny patch of retina responsible for everything you read and recognize, the kale in your cart. It actually does what you thought it did, omega-3s. You've probably seen the little omega-3 sticker on a bag of salmon at the grocery store. Maybe you've walked past a pharmacy display of fish oil capsules the size of horse pills. You've vaguely absorbed the message that these are good for something. You're just not exactly sure what. Here's what omega-3 fatty acids, specifically EPA and DHA, are essential for two completely separate things in your eyes. The back and the front. In the back, DHA packs into the membrane of every photoreceptor cell, keeping those membranes fluid enough to transmit visual signals at the speed your nervous system requires. In the front, EPA modulates the inflammatory chemistry of your ocular surface, dialing down the cascade that destroys the quality of the oil film, protecting your tears from evaporating. That oil film, the mebum, secreted by tiny glands along your eyelid margin, needs to stay liquid at body temperature to flow properly. Chronic low-grade inflammation stiffens it. EPA shifts your body's prostaglandin production away from the inflammatory version and toward the anti-inflammatory version. The oil flows better. The tear film holds together longer. What makes this different from general anti-inflammatory advice is the delivery system. Omega-3s from actual oily fish, salmon, mackerel, sardines, come packaged with phospholipids that absorb more efficiently than the synthetic ethyl ester form found in cheap supplements. If you're buying a capsule, look for reesterified triglyceride or RTG on the label. It matters more than the milligram count. 2 to 3 servings of fatty fish per week covers most of what the research supports. The giant horse pills are optional. The fish is better. Diabetes. You wake up. You're thirsty again, which is strange because you drank water before bed. Your vision is slightly blurry this morning. You figure it's just sleep. You've been figuring that for months. This is how it starts. Diabetic retinopathy is the leading cause of vision loss in working-age adults worldwide, and it works silently for years before announcing itself. By the time your vision blurs, the damage to the blood vessels behind your eye has been happening for a long time. What's actually happening is that excess blood sugar attacks the structural cells wrapping around your retinal capillaries, cells called pericytes, and kills them off over years. Once those cells are gone, the capillary walls weaken and balloon out into tiny pouches called microaneurysms. Then the vessels start leaking. Then, when enough vessels die off entirely, the eye tries to grow replacements. And the replacements are fragile, poorly built, and prone to hemorrhage directly into the gel inside your eye. What makes diabetic retinopathy different from other vascular eye diseases is that it's almost entirely preventable through glycemic control. Tight blood sugar management, the kind that keeps your HbA1c consistently below 7%, dramatically slows the rate at which those parasites are lost. Not slightly, dramatically. Studies like the DCCT trial showed a 76% reduction in the risk of developing retinopathy in type 1 patients on intensive glucose control. The catch is you have to start early. Once the vessels are gone, they're gone. The morning thirst is worth taking seriously. Blood pressure, your ophthalmologist asks you to look straight ahead at the little red barn in the distance. They're shining a light into your eye. They're quiet for a moment. Then they ask, when was the last time you had your blood pressure checked? Your eyes just told on your arteries. Hypertensive retinopathy is what happens when chronically elevated blood pressure remodels the tiny arterioles inside your retina. Your eye is one of the very few places in the human body where a doctor can look directly at functioning blood vessels without cutting you open, which means the retina is essentially a live readout of your vascular health. The damage follows a specific sequence. First, the vessels narrow and constrict in response to pressure. Then, over months and years, their walls thicken and harden, what you see on a fundus photograph as copper wiring or silver wiring, the vessels becoming more reflective as their walls calcify. Then, where a stiff arteriole crosses over a vein, it compresses it. That's AV nicking. In severe cases, hemorrhages appear, the optic nerve swells, and you develop what's classified as malignant hypertension. What makes this different from the other vascular threats is the speed of the final stage. A grade 4 hypertensive crisis, swollen optic nerve, macular star pattern of exudates, historically killed most patients within 3 years if untreated. Not because of blindness. Because of what it meant about their heart and kidneys, your eyes tell the story first, UV protection. You're at a beach or a ski slope, and the light feels almost aggressive, bouncing off the water or the snow, coming from every direction at once. You grab your sunglasses. You put them on. You stop thinking about it. What you probably don't know is that not all sunglasses protect your eye at all. Ultraviolet radiation splits into two bands that cause completely different damage. UVB, the shorter, higher energy wave, gets absorbed at the front of the eye. The cornea and the lens take the hit. Over years of unprotected exposure, UVB oxidizes the proteins inside your crystalline lens, causing them to clump together and turn cloudy. That's a cataract. It also damages the stem cells at the edge of your cornea, which can trigger the growth of a pinkish fibrovascular tissue across the clear part of your eye, a pterygium, also called surfer's eye. And not just for surfers, UVA, the longer wave, passes through the cornea and lens and reaches the retina itself. There, it generates reactive oxygen species that damage the RPE cells underneath the photoreceptors, accelerating macular degeneration. What makes protection tricky is that cosmetic sunglasses, the cheap ones at the counter near the register, often filter visible light without filtering UV at all. A dark lens that doesn't block UV is actually worse than no lens because your pupil dilates in the shade, letting in more radiation than it would have in bright light. What you need is a label that says UV 400 or blocks 100% UVA and UVB. Polycarbonate lenses block it automatically. Most premium lenses do. The $8 ones at the checkout counter, you'd have to check .wayware. You're doing something you've done 100 times, cutting something in the kitchen, doing something in the garage, maybe just mowing the lawn, and a small piece of something goes airborne and flies into your face. You blink hard, tear up, check in the mirror. Fine, just dust. Not always. Eye injuries are among the most preventable category of medical emergencies that people consistently fail to prevent. The American Academy of Ophthalmology estimates that around 2.5 million eye injuries occur in the US each year, and the majority of them happen in exactly those settings: home, garden, workshop, where people assume protection isn't necessary because the risk doesn't feel real. What's actually at stake is this: the eye has no ability to regenerate complex tissue once it's been traumatized. The retina doesn't grow back. The cornea can scar permanently in seconds, and the window in which a penetrating injury can be repaired before permanent damage sets in is measured in hours. Safety eyewear needs to meet the ANSI Z87.1 standard, which means it's been tested against a quarter-inch steel ball traveling at 150 feet per second. Regular glasses, even prescription ones, don't meet that standard. Polycarbonate and Trivex lenses are the materials that do, and they also block UV automatically. What makes this different from sunglasses advice is the context. Sunglasses are for chronic, low-level UV exposure. Safety eyewear is for impact, chemical splash, and flying debris. And you need both, because they protect against completely different threats. The one that almost got you in the garage? That's the one you don't remember happening. Screen time, it's 10 p.m., and you've been looking at screens since about 7 a.m. Your eyes feel like they're made of sandpaper. They burn a little when you blink. Everything at distance looks slightly soft for a few minutes when you finally look up from your laptop. You figure you're just tired. You are tired. But your eyes are also doing something specific. Digital eye strain is caused by two simultaneous failures happening on opposite ends of the eye. In the front, your tear film is breaking apart faster than normal because your blink rate has dropped from roughly 15 to 20 times per minute down to around 5 to 7. That's not an exaggeration. It's been measured by the American Academy of Ophthalmology and confirmed in multiple peer-reviewed studies. Your brain treats screen focus as a visual task so demanding that it suppresses the blink reflex to avoid interruption. The result is a corneal surface that's partly exposed to air for far longer than it's designed for. In the back, or rather behind the lens, Your ciliary muscle, which adjusts your eye's focal length for near and far distances, has been clamped in a contracted position for hours. That muscle fatigue is the "my eyes are sore" sensation you feel. What makes this different from general eye fatigue is that it's entirely structural, not neurological. You're not seeing worse because your brain is tired. You're seeing worse because your tear film is compromised and your lens muscle is exhausted. The fix is low tech. The 20-20-20 rule, every 20 minutes, look at something 20 feet away for 20 seconds, is validated by actual clinical outcomes. Your blink rate normalizes. The muscle relaxes. The film restores. 20 seconds. Every 20 minutes, blinking. Right now, without thinking about it, your eyelids just closed and opened. You didn't decide to do that. It happened. About 15 times in the last minute, it happened. And you didn't notice any of them. A blink is not just a lid reflex. It's a delivery system, a cleaning cycle, and a compression mechanism all happening simultaneously in about 150 milliseconds. Every blink squeezes the meibomian glands along your eyelid margins, expressing a thin film of oily meibum onto the lid edge, which then gets swept across the eye as the lid opens, sealing the tear film from above so the aqueous layer underneath doesn't evaporate. Incomplete blinks, where the upper lid travels partway down and stops without touching the lower lid. Skip the squeeze. The glands don't empty. The oil layer is never fully applied. And when this happens hundreds of times a day, the meibomian gland ducts can start to plug. What makes incomplete blinking particularly insidious is that it happens disproportionately during screen use, and people have no idea they're doing it. A 2016 study found that roughly half of all blinks during screen tasks were incomplete. The subjects weren't aware of a single one. The treatment for meibomian gland dysfunction, warm compresses to liquefy plugged gland contents, lid massage to express them, is just a deliberate, forced version of what a complete blink should have been doing all along. Your eyelids just did it again. That one, you probably noticed ergonomics. You're 4 hours into a work session. Your neck is stiff, your back is tight, and you've drifted forward until your face is about 18 inches from your monitor. You don't remember moving. You're just somehow closer than you started. That drift is doing something to your eyes you're not accounting for. The ideal distance between your eyes and a screen is roughly arm's length, about 20 to 25 inches. At that distance, the ciliary muscle inside your eye has to contract, but not excessively. At 18 inches, it's working noticeably harder. At 12 inches, where people end up on phones, it's near maximally contracted, which is the visual equivalent of holding a fist clenched for several hours. Street height matters for a different reason. When you look straight ahead or slightly upward, your upper eyelid rises, exposing more of the eye surface to air. When you look slightly downward, the ideal screen position, with the top of the monitor near eye level, the lid descends and covers more of the eye. Less surface area exposed, less tear evaporation, fewer dry eye symptoms. The difference is measurable. What makes workspace ergonomics different from general posture advice is that the eye symptoms are the earliest signal. Neck pain takes years to develop. Eye strain announces itself the same afternoon you're sitting wrong. Monitor too high? Dry eyes by noon. Monitor too close? Blurry vision at 5 p.m. The adjustments are small. The chair, the monitor height, the distance, the font size. None of them requires buying anything. Most of them require just moving things. Sleep. It's 2 a.m. and you're still awake. Not because you have to be, just because you're on your phone and inertia has taken over. You've done this enough nights in a row that you've stopped noticing how your eyes feel in the morning. A little gritty, a little slow to focus. Fine once you've been up for a while. That's not just tired. That's your cornea, the corneal epithelium. The outermost layer of cells covering the front of your eye runs on a maintenance schedule calibrated to sleep. During daylight hours, blinking and environmental exposure cause microscopic damage to those cells constantly. During sleep, stem cells in the limbal region at the edge of your cornea divide asymmetrically, producing daughter cells that migrate toward the center, climbing up through the layers to replace what was lost. This process runs primarily at night. Under the protection of your closed eyelid, sleep also resets tear film homeostasis. With the eye closed, there's no evaporation, no debris exposure, no inflammatory cytokines building up. The tear reservoir replenishes. The ocular surface recovers its chemical balance. What makes sleep different from other recovery recommendations is that no substitute exists. Artificial tears help when you're awake, but they don't replicate the closed lid environment that allows limbal stem cells to divide. There's no eye supplement that triggers corneal cell renewal. You have to actually be unconscious. Chronic sleep deprivation compromises the corneal barrier over time, increasing susceptibility to infections and reducing the eye's ability to tolerate contact lenses, dry environments, or long screen sessions. Your phone will still be there in the morning, hydration. You're mildly annoyed by your eyes in a way you can't quite locate. They're not painful, they're not red, they're just off. A little scratchy, a little dry at the edges. You've been indoors all day, in air conditioning, and you realize you've had maybe 1.5 glasses of water. That's actually a lot of the explanation right there. The aqueous layer of your tear film, the bulk of your tears, the layer that sits between the outer oil film and the inner mucin layer, is produced by the lacrimal glands, which are small glands tucked under the upper eyelid and in the corner of your eye. Like any secretory gland, they depend on systemic hydration to function. When blood osmolarity rises because you haven't drunk enough water, perfusion to the lacrimal gland decreases, and basal tear output drops. What follows is a cascade. Less volume in the tear film means higher salt concentration. High tear osmolarity is directly irritating to the corneal surface, and it also signals the cornea to downregulate mucin production, the molecules that help tears stick to the eye in the first place. So the tear volume drops, the composition degrades, and the dry eye loop begins feeding itself. What makes hydration different from the other dry eye interventions is the scale. No eye drop, no omega-3 supplement, no blinking exercise can compensate for a chronically dehydrated system. 8 glasses a day is imprecise advice, but the principle is sound. If your urine is dark yellow by afternoon, your eyes probably know it already. Water is the cheapest eye drop you'll ever take, smoking. Here's something that almost never makes it into the reason people try to quit. The cardiovascular stuff, yes. The cancer risk, yes. But not this. Smokers are up to 4 times more likely to develop age-related macular degeneration than people who have never smoked. They tend to develop it up to 10 years earlier. If they already have it, it progresses faster and responds less well to treatment. When a tobacco toxin like hydrogen cyanide enters the bloodstream, it attacks the retina, the lens, the optic nerve, and creates systemic inflammation in ocular tissues simultaneously. What's actually happening is that cigarette smoke generates massive oxidative stress, depleting exactly the antioxidants the retina depends on to protect itself, while simultaneously constricting the small blood vessels that supply the eye. It's a double assault. Less antioxidant defense, less blood supply. The retina is exposed and undersupplied at the same time. Cataracts develop earlier in smokers. A 2022 WHO-affiliated brief confirmed the link is direct and dose-dependent. The more pack years, the earlier the onset. The only treatment for a cataract is surgical replacement of the lens. What makes smoking different from other modifiable risk factors is the permanence of the damage. Quitting can slow AMD progression, but the cells already destroyed by years of oxidative attack don't come back. The timeline of harm begins with the first cigarette, not the diagnosis. Most smokers know smoking is bad for them. Almost none of them know it can blind them before it kills them. Alcohol. This one's quieter. Nobody talks about alcohol and eye health the way they talk about alcohol and the liver. It's almost never in the public conversation, but chronic heavy alcohol use damages the eyes along several independent pathways simultaneously. It depletes B vitamins, particularly thiamine B1, which the optic nerve needs to function. Thiamine deficiency from alcoholism can cause a specific condition called toxic optic neuropathy. Progressive, painless central vision loss as the optic nerve fibers die off. It's not reversible once it's advanced. The same B12 deficiency that causes peripheral nerve damage can damage the optic nerve by the same mechanism. Alcohol also disrupts the liver's ability to metabolize and transport vitamin A, which is essential for producing the visual pigment that allows you to see in low light. Night blindness, difficulty seeing in dim conditions, is an early clinical sign of vitamin A deficiency, and it's one of the under-recognized consequences of heavy long-term drinking. What makes alcohol different from the other lifestyle risk factors is the dose dependence. Moderate alcohol use has no well-established link to meaningful eye disease. The damage is a chronic heavy use pattern. Years of daily excess, nutritional depletion, and systemic inflammation working in parallel. There's also a genetic dimension. Tobacco combined with heavy alcohol use dramatically elevates the risk of triggering Leber's hereditary optic neuropathy in people who carry the mutation, a sudden, severe, often bilateral vision loss triggered by metabolic stressors that the gene variant makes catastrophic. The optic nerve doesn't get a second chance. Exercise. You go for a run. You come back. Your heart is working. Your lungs are working. You feel good in the general way you feel good after exercise. Your eyes also just did something measurable. And almost nobody tells you this. Aerobic exercise, running, cycling, swimming, brisk walking, acutely reduces intraocular pressure by somewhere between 2 and 8 millimeters of mercury within minutes of starting. That's a clinically meaningful drop. For context, the first-line medication for glaucoma lowers IOP by roughly 4 to 5 mmHg. Exercise can produce a comparable effect without the drops, the prescription, or the side effects. The mechanism involves the sympathetic nervous system expanding the trabecular meshwork. the drainage structure at the front of the eye through which aqueous humor flows out, while simultaneously reducing fluid production. The effect typically persists for an hour or two after exercise stops. With consistent aerobic training over months, the long-term reduction in baseline IOP can reach 4 to 5 mmHg in people at elevated risk, according to a published clinical study from the early 1990s that held up through later replication. Crucially, when exercise is stopped, the IOP returns to pre-training levels within about 3 weeks. The benefit requires maintenance. What makes exercise different from other glaucoma strategies is that it also improves insulin sensitivity, reduces systemic inflammation, lowers cardiovascular risk, all of which independently protect retinal vasculature. It's not just an IOP intervention. It's a whole system protective mechanism that happens to benefit the eye as a side effect. Every run is doing something back there. Wilt, you've heard that obesity increases the risk of diabetes and heart disease. That part you knew. But nobody usually includes the eyes in that conversation. They should. Excess body fat creates a state of chronic low-grade systemic inflammation, elevated C-reactive protein, circulating pro-inflammatory cytokines, persistent insulin resistance that damages small blood vessels throughout the body. The retinal microvasculature is among the most vulnerable. There's also a mechanical dimension that's less commonly discussed. In patients with high BMI, fat can accumulate within the bony walls of the orbit, the socket your eye sits in. That extra fat compresses the thin-walled ophthalmic veins that drain blood from the eye, and it can also compress Schlemm's canal, the circular drainage channel that aqueous humor flows through before leaving the eye. Less drainage, higher pressure, higher glaucoma risk. The fat inside the socket also increases the resting pressure behind the eye itself, which can push on the optic nerve from behind, a concern particularly in a condition called idiopathic intracranial hypertension, which disproportionately affects women with obesity and can cause papilledema and vision loss without any blockage or tumor. What makes weight different from other risk factors is the multiplier effect. Obesity raises the risk of diabetes, which raises the risk of diabetic retinopathy. It raises blood pressure, which raises the risk of hypertensive retinopathy. It raises IOP. Each pathway is independent. All of them converge on the same organ. The eye is downstream of everything. Eye exams. You haven't had an eye exam in a while. You'd know if something was wrong, though. Your vision seems fine. You can still read. Nothing hurts. That's exactly the problem. Glaucoma, early diabetic retinopathy, and macular degeneration all share one feature. They progress for years, sometimes decades, without producing any symptoms the patient can detect. Glaucoma kills peripheral vision first, and the human brain actively fills in peripheral blind spots using surrounding visual information, so you can lose 40% of your visual field and still pass a basic vision test. By the time the central vision is affected, the optic nerve damage is severe and permanent. The only way to catch these diseases at a stage where intervention is meaningful is to look directly at the retina and optic nerve, a dilated fundus exam, or to image the nerve fiber layer with an OCT scan, which can detect thinning years before any visual field loss is measurable. What makes the exam schedule different from other preventive health recommendations is the asymmetry. A missed dental appointment costs you a filling. A missed eye exam can cost you a decade of silent glaucoma progression. The earlier a diagnosis, the more options there are, and the simpler those options tend to be. A drop, a laser procedure, a dietary supplement, small interventions early, drastic ones late. The exam itself takes 30 minutes. The dilation drops are annoying. The alternative is discovering a serious problem when there are few options left. Genetics. You're filling out a form at the doctor's office and you reach the family history section. You check the box for AMD because your grandmother had it. You check the box for glaucoma because your father is being treated for it. You feel like you're just filling out a form. You're not. You're providing a risk profile. The genetics of eye disease are surprisingly concrete. A positive family history of primary open-angle glaucoma elevates your personal risk significantly, roughly 3 to 9 times the baseline population risk. For AMD, variants in 2 specific gene clusters, CFH and ARMS2, TRA1, regulate how aggressively your immune system attacks the retinal pigment epithelium under oxidative stress, and they account for a substantial portion of AMD heritability. People who carry the high-risk alleles of both genes can have a lifetime AMD risk 10 times higher than the general population. What this means clinically is that family history changes the exam schedule. Someone with a first-degree relative with glaucoma should begin annual dilated exams by 40, not 60. Someone whose parent developed AMD before 65 should be on AREDS2 supplementation decades earlier than someone with no family history. Genes are not destiny here. They're a multiplier applied to modifiable factors. A person with high genetic AMD risk who smokes, eats poorly, and never gets exams will likely develop it earlier and worse. The same person who doesn't smoke, takes their supplements, and gets annual imaging can compress that timeline significantly. The form at the doctor's office is doing real work. Fill it out carefully. Dry eyes, your eyes water. Not from emotion, just randomly, at inopportune times, usually in a breeze or a cold room. Counterintuitively, your eyes feel dry and then proceed to water. You've never understood this. Here's the mechanism. Dry eye disease is not actually about having too little water. It's about tear film instability, the three-layer structure that covers the eye breaking apart too quickly between blinks. When the outer lipid layer is compromised because the meibomian glands aren't producing quality oil, or the mucin layer is degraded because the corneal surface is inflamed, the film breaks apart in under 5 seconds instead of the normal 10 to 15. The cornea detects this and sends an emergency signal to the lacrimal gland. Produce tears now. You get a flood of reflex tears, the watering, but reflex tears are compositionally different from basal tears. They're more water, less everything else. They don't fix the film. They wash over a broken surface and drain away. What makes dry eye different from just needing more eye drops is the underlying cause. If the problem is meibomian gland dysfunction, clogged, thickened oil, then lubricating drops give you temporary relief while the real problem compounds. The glands atrophy when they're not expressing properly. The treatment is heat and massage to unblock them. In more advanced cases, in-office procedures like LipiFlow or intense pulsed light therapy are used to restore gland function. Artificial tears are a bandage. They help. They're not a diagnosis. Contacts. You've been wearing contacts for a few years. You know the rules, more or less. You sleep in them sometimes. Not ideal, but you were tired. You top off the solution in the case, rather than emptying and refilling it. You've rinsed a lens with tap water once or twice when you were traveling. Each of those behaviors has a name in the clinical literature. Each one has an associated risk. Sleeping in soft contact lenses reduces the oxygen reaching the cornea and stops the normal tear exchange that washes bacteria away from the ocular surface. The result is a microenvironment under your eyelid that bacteria find highly hospitable. The risk of developing microbial keratitis, a corneal infection that can scar the eye permanently, increases between 6 and 20 times depending on how frequently you sleep in them. That's not a theoretical risk. It's the most common cause of preventable corneal blindness in otherwise healthy young people. Tap water contains acanthamoeba, a free-living amoeba that doesn't cause problems in your gut but causes catastrophic, treatment-resistant corneal infections when it gets under a contact lens. It's found in tap water worldwide. The infection it causes, acanthamoeba keratitis, is associated with permanent vision loss in roughly 30% of cases. Topping off solution concentrates bacterial contamination and dilutes the disinfectant. Cases must be emptied, rinsed with fresh solution, wiped with a clean tissue, and left face down open to air dry. Cases should be replaced every 1 to 3 months. The lens sitting in your case right now is either being disinfected properly or it isn't. Rubbing. You rub your eyes. Everyone rubs their eyes. It feels good in a specific satisfying way. The pressure, the darkness, the brief relief from whatever itch or fatigue prompted it. But rub them hard enough, for long enough repeatedly, over years, and you are physically reshaping your cornea from the outside. The cornea is one of the few structures in the body with no blood supply. Instead, it's a precisely organized matrix of collagen fibers, the stroma, layered in perpendicular sheets that give it tensile strength. When you rub vigorously, you create mechanical shear force across that matrix. This upregulates inflammatory enzymes called matrix metalloproteinases, particularly MMP9 and MMP1, which degrade the collagen bonds holding the stroma together. Do this repeatedly, over years, and the cornea progressively thins. The weakened tissue begins to bow outward under normal intraocular pressure. The shape shifts from a spherical dome to an irregular cone. Focus becomes impossible without specialty lenses. That condition is called keratoconus, and it's progressive. In advanced cases, corneal transplantation is the only option. What makes rubbing different from the other behavioral risks is that it's reflexive. You don't decide to rub your eyes, you're already doing it when you notice. The underlying causes, dry eye, allergies, fatigue, habit, are what need to be addressed. Treating those removes the urge also. Rubbing introduces pathogens directly to the ocular surface. Hands are primary vectors for conjunctivitis and corneal infections. Even without the collagen damage, it's a mechanism of disease, hygiene. You wake up, you splash water on your face, you're ready. Maybe you washed your hands before putting in your contacts. Maybe you didn't. You touched your eye without thinking about it while reading this. Hands are the primary transmission vector for almost every common eye infection. Infectious conjunctivitis, pink eye, spreads through hand-to-eye contact with contaminated secretions. The adenovirus that causes the most common form can survive on hard surfaces for up to 30 days. Shared towels, shared makeup, touching your face after touching a contaminated surface. These are the roots. Mascara and eyeliner carry their own risks. Eye cosmetics have an internal expiration timeline that most people ignore. Mascara should be replaced every 3 months because the wand repeatedly introduces bacteria into an anaerobic tube that the preservatives can no longer fully neutralize by month 4. Sharing eye makeup is a direct transmission pathway. Using expired eye makeup is a slow-motion infection risk you're applying directly to the eyelid margin. Then there's demodex, microscopic mites that live in eyelash follicles and are present in most adults, but whose populations expand in older patients or in those who don't clean their lids regularly. They block gland ducts, trigger inflammation, cause lash loss. The sign of infestation is what looks like a tiny clear cylinder wrapped around the base of each lash, called collarettes. Treatment requires consistent lid hygiene with tea tree oil-based scrubs, 20 seconds of hand washing before touching your eye, a new mascara tube every 3 months. These are small numbers. The infections they prevent are not small. Allergies, your eyes itch. Not mildly itch in that urgent, impossible way that makes you want to just press your knuckles into your orbits and never stop. Spring did this to you, or the cat, or the dust. The specific trigger almost doesn't matter because the result is always the same. You rub, you get temporary relief, you itch harder, you rub more. That loop is the problem. Allergic conjunctivitis is an IgE-mediated mast cell response. Your immune system identifying a harmless pollen protein as a threat and releasing histamine, tryptase, and prostaglandins into the conjunctival tissue. The itch, the redness, the swelling. The reflex to rub provides brief mechanical relief because pressure briefly interrupts the itch signal. But rubbing also degranulates more mast cells, releasing more histamine, making the itch worse. The pharmacology here matters. Over-the-counter redness drops, the ones marketed as get the red out, are vasoconstrictors. They narrow the conjunctival blood vessels. They do not touch the allergic cascade at all. Worse, with chronic use, the blood vessels become tolerant and rebound, leaving you redder than before when the drops wear off. That's called conjunctivitis medicamentosa. They're also contraindicated in narrow-angle glaucoma. What works is a dual-acting agent, olopatadine or ketotifen, that both blocks the histamine receptor and stabilizes the mast cells before they degranulate. Cold compresses also help without any pharmacological risk. They constrict surface vessels and blunt the itch response without dependency. The redness drops are everywhere. The ones that actually interrupt the allergic cycle are one shelf over. Pollution, you live in a city. The air outside is fine. Not visibly gray, not acrid, just ordinary urban air. You're not worried about it. You're indoors most of the time anyway. Your eyes are still accounting for it. Airborne particulate matter, PM 2.5, the fine particles less than 2, 5 micrometers in diameter, penetrates through the tear film and makes direct contact with the conjunctival and corneal epithelium. These particles carry oxidative chemicals that trigger low-grade surface inflammation, degrade the mucin layer of the tear film, and over years of chronic exposure, increase the incidence and severity of dry eye disease. Epidemiological studies from high-pollution regions consistently show higher rates of dry eye, conjunctival inflammation, and oxidative stress markers in tear samples. Ozone specifically, particularly during summer heat and traffic peaks, reacts with lipids in the tear film, breaking down the meibum layer and accelerating tear evaporation. The mechanism is the same as the UV damage to pupils in the retina, just happening on the surface of the eye instead of inside it. Indoor air is not automatically cleaner. Cleaning products, office printers, adhesives, synthetic materials, all release volatile organic compounds that irritate the ocular surface, particularly in poorly ventilated spaces. Practical countermeasures. Wrap-around eyewear outdoors on high-pollution days, desktop humidifiers, preservative-free artificial tears on exposure days. None of them completely eliminate the burden. They reduce it. The air costs something even when you can't see what you're paying. Diet. You know what a healthy diet looks like. You've been told 100 times. What you've probably never been told is why it matters specifically for what's in the back of your eye. The macula, the small central region of the retina, responsible for everything sharp, everything you read and recognize and use to look directly at things, accumulates 2 dietary pigments, lutein and zeaxanthin, almost exclusively from food. The body cannot synthesize them. They arrive through digestion from eggs, dark leafy greens, orange vegetables, and yellow peppers, and they travel to the macula specifically because it has a receptor system that selects for them. Once there, they do 2 jobs simultaneously. First, they act as a natural blue light filter, absorbing high-energy, short-wavelength light before it reaches the photoreceptors underneath. Second, they serve as lipid-soluble antioxidants, neutralizing the singlet oxygen that the photoreceptors generate in the process of detecting light. What makes diet different from supplementation is the delivery package. Lutein and zeaxanthin from eggs come with healthy fats that dramatically improve their absorption. Leafy greens come with fiber, folate, vitamins C and K, and a matrix of compounds that work synergistically. The AREDS2 formulation works for people already at high risk, but no supplement replaces the underlying diet that builds the macular pigment layer in the first place. Build the pigment early, through food, over a lifetime, and the macula has a thicker buffer against the oxidative insult of decades of phototransduction. The eggs at breakfast are working harder than you think. Your cholesterol is a little high. Your doctor mentioned it. You've been meaning to do something about that. In the meantime, your eyes feel perfectly fine. Except cholesterol doesn't give you a warning. High serum LDL promotes the formation of atherosclerotic plaques in the carotid arteries, specifically the internal carotid, which supplies blood to the eye through the ophthalmic artery. If an unstable plaque ruptures, it can shed microscopic cholesterol crystals into the bloodstream. Those crystals, called Hollenhorst plaques, travel downstream until they lodge at an arterial bifurcation in the retina. Under a fundus examination, they appear as tiny bright yellow crystals at vessel branch points. They're often asymptomatic. You might not know they're there, but their presence is a documented indicator of significant carotid stenosis, and patients with asymptomatic Hollenhorst plaques have been found to have roughly a 4-fold higher stroke-related mortality compared to age-matched controls. If the embolus is large enough to block the central retinal artery entirely, the result is sudden, painless, complete loss of vision in one eye. A central retinal artery occlusion. The retina tolerates about 90 to 120 minutes of ischemia before sustaining permanent damage. It's a stroke of the eye, and it shares the same workup and urgency as a cerebral stroke. What makes cholesterol different from the other systemic threats is that it arrives in the eye visibly, in crystalline form, years before it causes a catastrophic event. The fundus exam is the window that catches it. The crystals in the retinal vessel are asking whether you want to see a cardiologist. Symptoms. Most eye diseases don't hurt. They don't announce themselves. That's what makes a few specific symptoms worth treating as emergencies, even when you feel otherwise fine. A sudden shower of new floaters. Not the 1 or 2 you've had for years, but many appearing suddenly, sometimes with flashing lights in the peripheral vision, is the classic presentation of the vitreous gel inside your eye pulling away from the retina. That's a posterior vitreous detachment, and most of the time it resolves without consequence. But in about 1 in 7 cases, the traction as the gel pulls away tears the retina. If liquid gets under that tear, the retina begins to lift from the back of the eye. That's a retinal detachment, and the clock starts immediately, a curtain or shadow crossing your visual field, a dark arc that covers part of your vision and doesn't move when you move your eyes, is the retina lifting. This is a surgical emergency. The window before that detachment reaches the central macula, after which permanent central vision loss is almost certain, maybe hours. Sudden, painless loss of vision in one eye, as if someone turned a lamp off on that side, is a retinal artery occlusion until proven otherwise. Urgent evaluation is required because the treatment window is under 2 hours, sudden severe eye pain with blurred vision, halos around lights, nausea, and a headache is acute angle closure glaucoma. Pressure spiking to dangerous levels inside the eye, capable of permanently damaging the optic nerve within hours. None of these require self-diagnosis. They all require the same response. Immediately call an ophthalmologist or go to an emergency room. The eyes that are on fire right now are the ones that can still be saved. Infections, pink eye. You've had it. You remember it being annoying, contagious, something that goes away on its own or with drops. And most of the time, that's true. But there's a category of eye infection that does not go away on its own. It starts the same way: microbial keratitis. A bacterial, fungal, or amoebic infection of the cornea itself presents with redness and pain that seems like conjunctivitis, until you notice that the light hurts in a way it didn't before, and that vision in that eye is blurring. A corneal ulcer can form within 24 hours. Untreated, it can perforate the cornea. In roughly 11 to 14% of bacterial keratitis cases, even with treatment, the patient is left with a permanently visible scar. Acanthamoeba keratitis, from tap water under contact lenses, is classified separately because the pain it causes is described as out of proportion to clinical signs. The level of agony people experience before the infection is even visible. And in 30% of acanthamoeba cases, permanent loss of visual acuity results despite treatment. Pseudomonas aeruginosa, the most common bacterial cause in contact lens wearers, can progress from mild irritation to corneal perforation in 24 to 48 hours in aggressive cases. It's not a wait-and-see infection. The distinction between conjunctivitis and keratitis is: conjunctivitis causes diffuse redness and discharge, rarely causes photophobia, and almost never impairs vision. Keratitis hurts when you look at light and your vision changes. If the light hurts and your vision is off, you have hours, not days, Aging, your grandmother had cataracts. Your grandfather had macular degeneration. You're 45 and so far so good. You've been thinking about this a little more lately. The eyes age in a predictable sequence, and most of it is manageable if it's caught in time. Presbyopia arrives first, usually in the early to mid-40s. The crystalline lens, which the ciliary muscle deforms to focus on near objects, gradually loses flexibility. Reading glasses become necessary not because the eye is failing, but because the lens can no longer change shape quickly enough. This is universal. There is no preventive intervention. The options are glasses, multifocal contacts, or laser surgery that adjusts the cornea to compensate. Cataracts develop in most people by their 70s. A clouding of the lens from the protein aggregation that accumulates over decades of UV exposure and oxidative stress. They're managed surgically when they interfere with daily function. The surgery, removal of the clouded lens and replacement with a synthetic one, is among the most commonly performed procedures in medicine and has high success rates. Dry AMD, the slow accumulation of metabolic debris under the retinal pigment epithelium, forming drusen, and the gradual loss of RPE cells develops silently in a large percentage of older adults. The AREDS2 supplement slows the progression to advanced AMD in high-risk individuals. There is no treatment to reverse it. Wet AMD, the abnormal blood vessel growth variant triggered by VEGF, can be treated with injections of anti-VEGF medication directly into the eye, which halt neovascularization and can preserve or recover some vision if caught early. The sequence is predictable. The timing is not inevitable. Environment, you're not an outdoors person particularly. You live in a temperate climate. You don't ski. You don't spend hours at the beach. You figure UV is mostly not your concern. But the inside of your house has its own environmental ocular load, and it's different from what you'd expect. Dry heating in winter removes humidity from indoor air, dropping room humidity to 20 to 30%, below the 40 to 50% range where tear evaporation is balanced. Every hour spent in that air accelerates the breakdown of the tear film. A desktop humidifier, restoring the room to 45%, makes a measurable difference to ocular surface stability over the course of a workday. Ceiling fans and air conditioners direct airflow across the eye, which strips the tear film at a rate proportional to airflow speed. People with dry eye consistently report worsening symptoms in air-conditioned rooms, and the mechanism is exactly what you'd think. Convective evaporation of the aqueous layer. Blue-violet light from digital screens, in the 415 to 455 nanometer range, is being studied for potential retinal effects. Although the current clinical consensus is that the energy levels from typical screens are far below the threshold for documented retinal damage. The more immediate evidence points to circadian disruption. Late evening screen exposure delays melatonin onset and reduces sleep quality, which circles back to the corneal regeneration problem. What makes the indoor environment different from the UV conversation is that people are exposed to it more hours per day than anything outdoors. The modification is simple: a humidifier, fan positioning, monitor settings. The most dangerous environment is often the comfortable one. Prevention. There is no single intervention that covers all of this. There's no supplement that replaces exercise. No exam that substitutes for diet. No sunglasses that compensate for smoking. What actually works is layers. Diet and omega-3s build the retinal substrate. Sunglasses and safety eyewear intercept the acute damage before it accumulates. Blood pressure, blood sugar, and cholesterol management protect the vasculature that feeds the retina. Sleep maintains the corneal barrier. Hydration maintains the tear film. Exercise reduces intraocular pressure. Not smoking removes the most potent modifiable risk factor, AMD and cataracts. Regular exams catch what none of the above prevents. None of these are exotic. None of them require expensive interventions or medical procedures. The research supporting each one is extensive. Published in the most scrutinized clinical journals in ophthalmology. Confirmed in trials involving thousands of patients over years of follow-up. The eyes are the only part of the central nervous system directly visible from the outside. They're the only place where a doctor can see your blood vessels, your optic nerve, and your brain tissue without cutting you open. They spend your entire life delivering a resolution of experience that no camera or screen can replicate. They do all of that while being surprisingly fragile and quietly. The window you see through is finite. The choices that keep it clear are not complicated. They're just easy to defer. If you liked this video, leave a thumbs up. But if you really liked it, hit subscribe for more, and drop new video ideas in the comments.